Our next abstract will be presented by Dr. Barbara Eichhorst from the University of Cologne. It was one of the late-breaking abstracts, and I will just briefly highlight that we had 45 late-breaking abstracts of exceptional quality this year. So the ones that are selected are really, really very important studies or results. This is time-limited Venetoclax-Obinutuzumab plus or minus Ibrutinib being superior to chemoimmunotherapy in frontline CLL. So this is the PFS co-primary endpoint of the randomized phase 3 GAIA CLL13 trial. Thank you very much for coming to present this today and presenting it at the EHA, at the late-breaking abstracts.
Thank you very much, particularly to the EHA board and the scientific committee for selecting this as late breaker. I'm really truly honored to present that on behalf of my colleagues. We were a research consortium of 6 study groups in Europe and Israel, including 11 countries in Europe working on this clinical trial. Here are my disclosures. And just as a short introduction for those who don't treat CLL patients daily, so when patients achieve advanced stage, our treatment decision in Europe at least is guided as shown here by the EHA guidelines according to genetic risk factors as TP53 operation, mutational status, but also to the age and fitness of the patients. And as you can see, for elderly or unfit patients, we have the option between targeted treatments, including long-term treatment with BTK inhibitor, as well as time-limited treatment with the BCL2 inhibitor, Venetoclax, in combination with Obinutuzumab, based for the latter one on data from the CL14 trial in this elderly patient population. We do not yet have data in a randomized phase 3 trial for the fit patients on Venetoclax plus Obinutuzumab, and therefore we treat those patients in many countries in Europe either still with chemoimmunotherapy when they have a favorable karyotype, or favorable IGVH status, or with continuous treatment with BTK inhibitors. And therefore, we as a research consortium in Europe wanted to address the question within this 4-arm randomized trial in fit patients who were selected by a fitness score as well as normal creatinine clearance between the standard chemoimmunotherapy with FCR or BR, and due to that all patients were centrally screened for TP53 mutational operation and were then excluded, or 3 different arms, all of them containing 12 months of treatment with Venetoclax. And the study has 2 co-primary endpoints with an alpha split to 2.5%. The first endpoint was already met last year. That was the rate of undetectable MRD at month 15 in the peripheral blood measured by flow between Venetoclax-Obinutuzumab and chemoimmunotherapy. And we will present here now the second co-primary endpoint, the PFS interim analysis for a triple combination combining Venetoclax-Obinutuzumab plus Ibrutinib, given also at least for 12 months with the possible extension up to 36 months. And there was also a 4th arm, Venetoclax plus rituximab, included, which was also allowed to be analyzed according to a statistical hierarchical ranking. So overall 920 patients were included, and now after follow-up time of 38.8 months, we see the interim PFS analysis here that with the black curve, the triple combination Venetoclax-Obinutuzumab plus Ibrutinib was clearly superior to chemoimmunotherapy with FCR for the younger patients or BR for the elderly patients who were fit with a hazard ratio of 0.32. Also, the Venetoclax-Obinutuzumab therapy was clearly superior with a hazard ratio of 0.42, but Venetoclax plus rituximab was not superior. So it depends also on the antibody which you combine to the Venetoclax treatment. Looking at the 2 major subgroups in CLL patients with mutated and unmutated IGVH status, on the right-hand side, we see again that particularly prognosis is favorable for patients with mutated IGVH status, where there's not such a big difference between in blue chemoimmunotherapy and the targeted agents, but we see a huge difference particularly for patients with unmutated IGVH status. With respect to the side effects, shown here all CTC grade 0 higher side effects in 5% of the patients. There were no major difference, particularly not between the 2 arms containing Venetoclax plus Obinutuzumab, with the exception of higher rates of infections and febrile neutropenia with the triple combination as well as with the chemoimmunotherapy. With that, I would like to summarize the results of the study. So time-limited targeted therapy with venetoclax plus obinutuzumab with ibrutinib or without ibrutinib is superior to chemoimmunotherapy with respect to PFS, also with respect to undetectable MRD rates. In particular, patients with unmutated IGVH status benefit from this targeted therapy, and higher infection rates were seen with chemoimmunotherapy in the triple combination. And the question with respect to the head-to-head comparison of the triple arm versus the doublet arm, what is the additional benefit of ibrutinib? We will be able to analyze that next year with the next follow-up. Thank you very much, and I'm happy to take questions.
Thank you very much. Thank you for submitting and presenting it this year. And again, I just want to highlight this is a large academic trial with multiple arms, huge collaboration effort, which really goes to answer the questions that we as physicians have. So I think that is a very important point, in addition to your positive results, of course, but a very important point to bring out. Are there any questions? Thank you.
Just a quick question. So to clarify, the benefit is the fixed duration. So is it a shorter course then than the various alternatives?
Correct. So for the alternative would be for CLL patients to give them a BTK inhibitor as continuous treatment forever or until patients stop due to side effects. So BTK inhibitors are very well tolerated, but if you have to take a drug for 3 or 4 years, in particular in these young patients, they may have to take the drug for 10 or 15 years. Even CTC grade 1 and 2 side effects might become a problem after some time. And therefore, the combination we evaluated here was lasting only for 12 months of treatment. It's a type of intensified treatment because BCL2 inhibitors in CLL have shown that they, due to the induction of apoptosis, they are truly able to eradicate the disease, at least to that what we can measure right now. While we know that with the BTK inhibitors, we have a consistent lymphocytosis, so the symptoms are very well controlled. So the benefit for patients, at least that's our aim from this research consortium, is to achieve also not only good treatment of the symptoms of the patients, but also long treatment-free intervals for the patients. And as the data show here, this is obviously possible with this combination.
Okay. And does that also help with resistances?
Yeah, that's one of the key questions, because that's also why, or we know that, for example, with years on treatment on BTK inhibitors, resistance mechanisms may occur, and we have to admit we don't know yet for these targeted treatment combinations with venetoclax. We have some data from the CL14 trial for the elderly patients that at relapse, so far patients have not developed, for example, these BCL2 mutations. So it seems that the majority of the patients was very restricted due to the low number also of relapses. They don't develop resistance mutations when they come off treatment in between.
Great, thanks.
I think another interesting finding, which reinforces something that we have seen in the past, is the fact that obinutuzumab has a different effect to rituximab, even though they are both antibodies against CD20. And do you have some explanation for this, or it's something that we've been observing again and again, and it's so comforting or reassuring to see in a head-to-head trial like you've designed?
Yeah, I have to admit we were also surprised about, and we expected a difference, but we did not expect such a large difference, to be honest. Of course, which was also debated in combination with chemotherapy, there is a different dosing, and we give 8 doses of obinutuzumab versus 6 doses of rituximab. So certainly the dose also plays a role, but it might be just to the different acting of mere ADC activity of this antibody. Probably, I assume also due to the much faster clearing of the blood of the CLL cells at the beginning, and therefore also probably better synergism between venetoclax plus the obinutuzumab antibody, maybe also faster immune reconstitution. There are many possible mechanisms for that, I think.
Thank you. But it's certainly very interesting. I think it highlights an important point that not all cats, even though they're cats, have the same color and have the same effect. So I think it is this sort of trial that may even be almost counterintuitive in a way, gives us important indications for questions and answers. So thank you very, very much for presenting this.
Thank you.
Thank you.